This voiceover will review amputations. People can have amputations for a variety of reasons. Trauma and surgical removals can be some of the main reasons. About 185,000 people have amputations a year in the United States. And sadly, many of these are done because of peripheral vascular disease, especially related to diabetes. If a younger person loses a limb, it's generally secondary to trauma. And 1,700 veterans since 2003 have lost one or more limbs. Other causes can be thermal injuries, tumors, osteomyelitis, which is infection of the bone, and congenital limb disorders. So before proceeding with an amputation, it's crucial to effectively manage chronic illnesses and infections. The surgical objective is to retain the maximum length and function of the extremity, while eliminating any infected, pathological, or ischemic tissue. Figure 67.23, which is on the next slide, illustrates the various levels of amputation for both upper and lower extremities. The specific types of amputation performed is determined by the underlying reason for the surgery. In a closed amputation, emphasis is placed on creating a weight-bearing residual limb or stump. This involves covering the bony portion of the residual limb with an anterior skin flap, which is padded with dissected soft tissue. The skin flap is then sutured posteriorly to ensure that the suture line is not positioned on the weight-bearing area. It's really important to make sure that prevention of accumulation of drainage, because this can cause pressure and provide a breeding ground for bacteria leading to infection. So this is the image from your textbook showing the different places where they can do the amputation. When it does go through a joint, it is considered disarticulation, just the name going through a joint. And that's, the big part about this slide that you need to know. So obviously there are some major psychological, possible social implications of an amputation. Body image is going to be affected. Preoperatively, the reasons for the amputation and prosthesis and mobility trainings will vary based on, what's being amputated and how old the patient is and what other issues there might be. Generally going to include strengthening exercises, and then postoperative, we're going to be worried about positioning, support, residual limb care, meaning the part of the limb that is left over, compression bandages, and ambulation expectations. Now, phantom limb sensation is real, and it's thought that up to 80% of people who have had an amputee actually experience this kind of pain. It may be shooting, burning, crushing pain. They could feel coldness, heaviness, or cramping. Remember, we treat the pain. We're going to treat this, especially immediately in the immediate postoperative phase, with opioids. This pain is real. Their brain has not realized that that limb is no longer there. The pain can subside, or it can be chronic. Mirror therapy, where they're actually going to use a mirror to show the brain that the limb is not there, helps to get the brain to realize that sensory feedback in the brain that it's not there. Now, postoperative care, again, it's going to depend on whether this was planned or traumatic. Obviously, one that is not planned and traumatic, we're going to be watching for PTSD. We're going to be watching for and identifying complications such as watching our vital signs, watching for hemorrhage or infection. If they get an immediate prosthesis, have a tourniquet available in case there would be some bleeding. If they don't have a prosthesis, then they're going to need to learn how to get into a wheelchair for mobility. Many patients actually have delayed prosthesis, and this allows that residual limb, to get to the correct size, and so that helps them have better success with it. Sometimes a patient will have a temporary prosthesis where they're allowed to do some partial weight bearing until they get that permanent prosthesis. The patient's going to need to be active in range of motion and strengthening exercises, trying to get ready for mobility. They're going to have altered balance. Proprioception, which is basically the body's kinesthesiology. It's the ability to sense movement and action and location of the body. Without it, we would have to think about every single movement we're going to do. And so this proprioception and coordination are addressed to prevent people from falling and then having other injuries. We're going to potentially teach crutch walking, and then patient and caregiver education is going to be residual limb care, ambulation, contracture prevention, being able to identify complications, exercise, and follow-up. So I added this picture from the textbook, and it's just showing proper way to bandage if somebody has that above the knee amputation. And in order to do that proper bandaging, that's going to help shape that residual limb and help it have a better prosthetic fitting. So they'll usually use an elastic bandage, and then they'll add a limb shrinker over it. And I added this picture here just to show you what a limb shrinker would look like, and this would go over the limb there to help get it to get to the correct size. So this slide is probably one of the most important slides in my opinion. It's going to be teaching for that lower extremity amputation. We are going to teach them to inspect the limb daily, and so we're going to want them to look at that, and if they can't see it all, they're going to have their family member be looking at that, looking for any skin irritation, especially any redness or abrasions, any odors, especially anywhere that's really prone to pressure. If they do notice any irritation, they need to stop using that prosthesis right away. They should wash the residual limb thoroughly each night with warm water and something like a bacteriostatic soap like Dial. Then they're going to rinse it thoroughly, dry gently, and keep that residual limb open to air for 20 minutes. And this is okay, of course, once it has been approved by the healthcare provider. They need to only use a good residual limb sock if it's in good shape. If it is not in good shape, then they need to not be using it. They should change that daily, and they should wash that in the sink, rinse it out, and then lay it flat to dry. Patients should be doing range of motion to all joints every day and performing their general strength exercises, including the upper extremity, daily. They should never elevate the limb, that residual limb, on a pillow. The problem with elevating the limb on a pillow is they can get contractures there. And so in addition to that, we're also going to have them lay prone with their hip in extension for 30 minutes, 3 to 4 times a day. And that's a pretty common NCLEX style question I see for those lower extremity amputations. And then again, in the outpatient setting, they'll get fitted for their prosthesis. They'll be taught how to care for it. Again, we need to make sure that we're taking care of them emotionally as well. And if somebody has had an upper extremity amputated, those prostheses don't give the same type of movement and functional capacity. Below the elbow, immediate and delayed fittings are available. Above the elbow is going to be a delayed fitting, and it's usually going to be that kind of arm and hook. There are some cosmetic prosthetics, but they really are there for cosmetic, and there isn't, any function to them. And then in the end, we're hoping that the patient is able to accept the change in their body image, that they don't end up with any breakdown, they're able to have decrease or absence of pain, and that they become mobile with limitations, minimal limitations imposed by the amputation.